Good morning, everybody. Welcome to this morning's event. My name is Eddie Cassidy, and I am the chairman of ILFA. Today we hold our third virtual Patient Information Day of 2021, and I would like to thank the organisers and speakers for their help with this event. And we hope that with technology working at its best, we will be able to provide a very good morning's talk. We have a great lineup of speakers today, and we are thankful to them for their knowledge, their expertise, and I hope you will enjoy all of their presentations. The order of speakers this morning is Dr. Aidan O'Brien, Gráinne Murphy, Maria Love. We will then take a short comfort break, and we will rejoin with Patricia Jones, Dr. Cian O'Leary, and Annette Crennan. Questions will be submitted via the chat function on the bottom of the screen and will be raised after each presentation. So, our first speaker is Dr. Aidan O'Brien. Dr. O'Brien is a consultant respiratory physician at University Hospital Limerick. After qualifying from University College Galway, he has worked in many renowned hospitals in the USA and returned to Ireland in 2002. Dr. O'Brien has completed and published basic science and clinical research. Dr. O'Brien is president of the Irish Thoracic Society, and we are delighted to welcome him as our first speaker today. Dr. O'Brien's presentation is entitled Idiopathic Pulmonary Fibrosis. So over to you, Doctor.
Thank you very much for the invitation, Eddie, and to ILFA. First of all, to compliment ILFA for all the great work you've been doing as a patient support group. Again, it's something that has developed in my time here, and I've witnessed it grow from strength to strength. I compliment ILFA for fabulous work from beginnings, starting off on a very small scale in Dublin and now nationwide, and an absolute credit to your organisation, and long may it last and grow to even greater strength than you've already achieved. And I'm delighted, and it's a pleasure to talk to you all this morning about a disease that's close to my heart. And I've worked with for a long time, from basic research with it in Ann Arbor, University of Michigan, back in the 90s, to caring for patients with interstitial lung disease throughout my last 20, 30 years, and also, let's say, doing some research in the area as well. Brilliant, excellent. Sorry about that. And this is just saying what pulmonary fibrosis is. Now, let me see if I can move on the slides now. That slide isn't doing it.
If you just hit on your PowerPoint there and just down the bottom there.
And then some of these other statements are names known as UIP, or usual interstitial pneumonia. And this now has been more reserved for what we look at on the X-ray or the CAT scan. That's what it really describes. And so, not to get people confused, and really now the term everybody's using internationally is pulmonary fibrosis, or idiopathic pulmonary fibrosis. There are many other diseases that can cause scarring of the lung that are idiopathic or secondary to exposures such as asbestos, silicosis. There are diseases unique that are genetically based, like sarcoidosis, or diseases due to autoimmune diseases, known as such as rheumatoid or lupus. And all these can also lead to progressive fibrosis of the lung. But what we're focusing on today are the idiopathic. And idiopathic, we mean, is by an unknown cause. Prevalence figures vary, and we don't have great population-wide statistics, but it's thought to estimate that between 6 to 14 people per 100,000. The prevalence does increase with age, and it may be up to 175 per 100,000, almost 1 in 200 people over the age of 75. So the older we're living, as we're now surviving and preventing all the cardiovascular problems, which was the commonest cause of death, and in our 50s and 60s, as we're now have a better quality of life and better diets and more exercise, we're living now to older ages, and now the older, you might say, the older diseases are now getting us. And one of those is pulmonary fibrosis. More common in males slightly, median age, the average, the more commonest age to present is in the 66 years of age group. and it can occur in families, and that's a well-known entity, but it's rare. The prevalence of pulmonary fibrosis is getting more common with the years. This is 2001, and you can see the prevalences from 202 per 100,000 up to almost 500 per 100,000 people over that decade. And again, I believe this is not disease is becoming more is that we're developing more prevalent in the population, which just the population is aging, and as a result, that's the reason why. The median survival, we know, is about 4 years when it's untreated. This again is just showing that as you get older, that the prevalence of the disease rises progressively, slightly more common in males. It was why it happens in people. Initially, it was thought to happen after some ongoing inflammation in the lung, and we initially were treating this disease with anti-inflammatories. But we then realized that really that's not what's happening, and really what it's felt to be is more a progressive fibrosis or an abnormal, you might say, response to insults to the lung. And instead of having inflammation and recovery, it's leading to scarring of the lung. So an abnormal response to an injury to the lung. And this scarring, unfortunately, then is irreversible. What causes this scarring? There are many, many different thoughts, such as metal dust, wood dust, reflux, and viral infections. The older you get, the more abnormal your response. Gastroesophageal reflux is thought to be an aggravating factor, and why we would commonly put people on preventative medications for reflux. Gender, are there things in the environment you're exposed to that's causing it? And again, there have been many different studies trying to evaluate this, but nothing concrete has come out of that. We do know your genetics, your family history does increase your risk if there's other family members. Cigarette smoking definitely is a risk factor as well, but definitely not the sole cause, unlike other diseases. How do people present? Most common symptoms tend to be chronic dry cough or breathlessness. Other symptoms you may get are fatigue, or it may be noted on exam that you get some what we call clubbing, that's kind of increased rounding of your nails and your fingers or toes. That's usually more an advanced disease. Your oxygen levels may start dropping down. And when a physician or healthcare provider listens to your lungs, they hear this distinct scarring of the lung, which comes across as a crackles when you listen to someone's lungs with the disease. The symptoms people get tend to come on very gradual, of kind of an increasing breathlessness and a cough, and almost you'd kind of ignore it initially, but as time gets on, you get used to this breathlessness. But over time, you eventually get to a level where you suddenly think, this is in excess of what I would have expected for my age. And a lot of people put down this breathlessness just to their age and getting unfit and pay no attention to it. And it's very often late into the disease when people present. And the average is almost 9 months after the symptoms develop that people present. 5% of people are said to be asymptomatic at the time they're diagnosed, and this is often because of an incidental chest x-ray picking up abnormalities. The crackles, like I mentioned, when you listen to someone's lungs, and the clubbing up to 50% of people. Some people actually can present late enough that their oxygen levels are quite low. It's very important to make sure they don't have any extra pulmonary involvement, and patients usually, if they do, then it would suggest an alternative diagnosis, and people don't tend to suffer from fevers or chills or night sweats. Again, if they are present, it would suggest an alternative diagnosis. The blood work in general doesn't really help. It helps to rule out other causes, but doesn't help rule in the diagnosis itself. So we would do routine tests as healthcare providers to assess for other causes of scarring of the lung, especially looking for things like autoimmune diseases. We do lung function tests as part of the diagnosis. And this is a classic picture where the lungs are shrunken down, and so the volumes you measure in the lung are reduced also. And what we do is a measure of gas exchange in the lung called the diffusion capacity, and that also is reduced. And finally, the oxygen levels tend to be low in addition. And you'll often see these charts being pulled out when you're seen by your healthcare provider, and it'll show numbers like this, which are reflective of someone's lung function. And we measure with lung volumes. Forced vital capacity is a measure of lung volume. And here this one is 61%, or a total lung capacity, TLC, at 58%. And down here at the bottom is the diffusion, and that shows it at 48%. So it's somebody with severe restriction of their lungs due to their pulmonary fibrosis. The X-ray is also part of this diagnosis, and this classically shows a inflammation at the edges of the lung and the bottoms of the lung. Rarely it may be normal because the X-ray isn't as sensitive as a CAT scan. This is like a classic looking X-ray. Normally you expect both these lungs. This is your right lung, this is your left lung, this is your heart, and this should be all black. Black because the lung should be full of air. Same with this lung, should be all black, but it's not. There's a lot of whiteness superimposed on the blackness, and this is indicative of the scarring of the lungs. These are just some other examples of patients of mine with scarring of the lungs. The CAT scan, this shows again this whiteness on top of the blackness. The whiteness being it's a scarring of the lungs. It tends to be both lungs, at the edges of the lungs, and it also gets these little holes in the lung, like a honeycomb, and that's indicative of advanced scarring. And the airways that go to those parts of the lung are pulled open, and we call that bronchiectasis, and architecturally distorted. So the normal structure of the lung is all distorted. There's very little inflammation in the lung, and it starts off usually at the bottoms of the lung and gradually goes up to involve most of the lung. The example is like this. This is a CAT scan image, and all these holes are what we call the honeycombing. All these holes in the lung which shouldn't be there. The normal lung should look like this. But as you can see, this lung is very abnormal. And these big tubes you see like this, these are the airways, and they're much, much larger than they normally should be because these airways are being pulled open by the scarring of the lung. And these airways then are predisposed to infections and cough and mucus. These are more examples. It usually tends to be at the edges of the lung, like this here. And more examples of that. Again, this is a person with early disease. You can see some little scarring. In fact, his initial chest X-ray or CAT scan was way back here. This was back in 2012, and this was in 2015. And back then, he had subtle changes where his airway was slightly dilated, and there's a little bit of scarring here, which we'd often not pay much attention to. Literally 3 years later, you can now see honeycombing, and this disease has progressed onwards. So again, a slow, insidious progression of the disease. We will do bronchoscopy, and we do sampling of the lung, and if needs be, we'll also go for a bigger biopsy of the lung, which can be done via do a video-assisted thoracoscopic surgery, where literally under general anesthetic with little video scopes with 1 inch cuts in the sides of the chest, and put little video scopes into those cuts into around the lung and get a biopsy of the lung. These are in cases where we're not sure of the diagnosis, but where you saw CAT scans like the ones I showed you in the appropriate patient, we would have enough in that to make a diagnosis. And there are other ways of obtaining tissue to get a diagnosis. When we get these biopsies, we send them to the pathologist who looks at them microscopically and looks for a classic picture. And often they'll see changes like this. These are biopsies of the lung, and these are the normal lung here with the air in it. And these big pink bands are areas of scarring of the lung. And here in greater magnification, you'll see these lumps. These are all cells. These individual things like this are cells, and these are fibroblasts. These are special cells that are overreacting and are producing a lot of the scarring of the lung. We call this a fibroblastic foci, if you ever want to go into the technical details of the disease. And these are more examples of it, these fibroblastic foci. And this is the normal lung here with the scarring right beside it. So in most cases, the diagnosis can be made on the history, the examination, and on the CAT scan findings. But where things are not quite clear, then we want to go ahead and get biopsies. There are many different diseases that can be or mimic pulmonary fibrosis, like drug-induced disease, sarcoidosis, fibrosis of the lung associated with rheumatoid arthritis and other diseases like that, occupational diseases such as asbestosis, that's people who work with asbestos, or people who work down in the mines called silicosis. So many diseases we would assess for that could mimic pulmonary fibrosis, and it'd be important to make that distinction because the treatments can be slightly different. How do we manage this disease? Well, there are many different treatment options out there, but first you've got to decide on it's influenced by the context of the individual patient's clinical condition. What other disease do they have? What does the patient want, particularly in view of the unpredictable nature of this disease? And I'll talk more about that. The treatment effects, and there are some side effects from treatment. Again, we always assess people for, do they need supplemental oxygen? And there are strict guidelines out there about who needs oxygen, who doesn't. And we base that on your oxygen level. And so if it's not below a level of 7.3 kilopascals, then you don't need oxygen. However, if it is, then definitely there's a benefit to being on oxygen. That's supplemental oxygen. Also, if your oxygen level is normal when you're sitting or resting, and if it only drops when you exercise, there's been science has shown that if you give people oxygen when they exercise, then they feel better, they can walk further and faster. Pulmonary rehabilitation is really, really important. This is usually an 8-week program, usually twice a week, 2 hours duration, and involves education and exercises for the lung that really, really can help with your breathlessness and your exercise ability. And without fail, patients find great benefit from this. The beauty is that there's no side effects. It's very social, very safe, and of great benefit. And it's usually a very free service to all patients. We often put people on protection against gastroesophageal reflux disease, and this is something that you imagine you expect most patients to receive. And then very, very important is vaccination, because we want to minimize all insults to the lung that could aggravate the fibrosis of the lung. And so it'd be very important to get the influenza vaccine and the pneumococcal vaccine, and obviously the corona vaccine for the COVID. And palliative care. Palliative care play a very important role in people with advanced lung disease, whatever the cause, be it pulmonary fibrosis, COPD, asthma, because what they deal with is the breathlessness associated with advanced lung disease. So unlike we always associate palliative care dealing with people with cancer, malignancy, they also have a very, very important role to play with people with advanced lung disease, to deal with the breathlessness aspect of things and the coughing. Very great, very good at managing the symptoms associated with this disease. There are many different therapies out there that were tried, and I've witnessed a lot of these. I'm involved in some of the trials, and really, unfortunately, not many of them showed any great benefit. In fact, some were actually detrimental. However, we've been very, very fortunate with having now 2 very effective agents for pulmonary fibrosis. I'm sorry now, I just should put my phone on mute. These 2 medications are nintedanib and pirfenidone. Both these drugs have shown to slow disease progression and maybe even an effect on mortality. They're for patients with mild to moderate pulmonary fibrosis. We've diagnosed that based on their lung function tests, who don't have significant liver disease. The data as to choose which one is most optimal for patients is insufficient to make that distinction. They both seem to be as effective as each other. And it really comes down to choosing which medication suits which patient, because they have different side effects, though most patients tolerate them very, very well. First, there's pirfenidone or Esbriet, and for the patient, I'm sure many of you are on this medication, but to know that both of those medications appear to be equally effective. Pirfenidone is an antifibrotic agent. That means it stops scarring of the lung. It works by blocking what they call an agent called TGF-beta, which stimulates the production of scarring of the lung. It slows the progression of the disease. It should always be taken with food. And it's very important to have your liver function tests checked frequently initially, that is monthly for the first 6 months, and then every 3 months afterwards. Again, most patients tend to tolerate it without being a problem. It's given in doses of up to 40 milligrams per kilogram to a maximum of 2,400 milligrams per day, usually in 3 divided doses. You start off with 1 tablet or 1 capsule 3 times a day at 267 milligrams. And after a week, the dose is titrated up. And after the second week, it's titrated up to the full dose, which is 3 capsules 3 times a day. And more recently, they have put those 3 capsules into 1 big capsule, which you can take 3 times a day. Most common side effects tend to be rash, photosensitivity, some nausea, some diarrhea, abdominal discomfort, anorexia, and fatigue. Though most patients, again, as I say, tend to tolerate it quite well. You can interact with other medicines, and it'll be important for a healthcare physician to know about what you are on medicine. Sorry here now, I seem to have pressed the wrong button here, and we close this out. Can people still see my screen?
We can indeed, yeah. Maybe, yeah, there we go. Yeah.
Now, nintedanib is the other very effective agent. Nintedanib, this acts by a different mechanism. It blocks a receptor called tyrosine kinase. This, again, has been shown to slow the rate of progression of the disease. It's usually given at 150 milligrams twice daily, usually 12 hours apart. Again, you've got to watch the liver function tests, and we would try to avoid in people with severe liver disease. Now, again, the liver function tests need to be monitored monthly for the first 3 months and every 3 months afterwards. And these reflects the effectiveness of these drugs. The average loss of lung function in people with pulmonary fibrosis, and this is in one of these large studies, was about 200 milliliters per year. But with this therapy, it halved it down to 110 milliliters per year. This is looking at the exacerbations you can get from pulmonary fibrosis. And again, it reduced the number of exacerbations over the space of the year. Also, this is a measure of quality of life. And the higher the number, the worse your quality of life. And again, it improved patients' quality of life. So not only did it stop the progression of disease and lower the risk of having an exacerbation of the disease, it also improved how you felt. And similar data has been shown with pirfenidone, almost identical. Again, this drug interacts with some other medicines, and it's very important that you have a list of your medicines with you every time you see your healthcare provider. And the side effects, mainly focusing on the bowels again, diarrhea, nausea, vomiting, and liver function tests can be elevated. Not as much of a problem with rash or photosensitivity. The other agent, pirfenidone, because that photosensitivity can be a significant issue, again, it's highly advised that they wear highest factor they can wear whenever they're out in the sun. How we monitor the effectiveness of the disease is based on your exam, your symptoms, and also the pulmonary function tests. And we'd want to measure the lung volumes, particularly focusing on what we call the forced vital capacity and the gas diffusion. We look for a 10% or more change in those, and that would indicate a significant worsening, because less than that can be just a normal variation in the testing technique when you're doing it. Transplantation is an option for people with diseases progressing significantly, to a significant enough level. And we like to refer people for transplantation evaluation sooner than later if they're suitable for it and if they need it. The reason is that between being evaluated and decisions made, it can take up to, a year or more. We'd consider transplantation, but again, you have to be less than 65 years of age, because when your age is over that, transplantation is a higher risk of dying, actually. So it's not a good thing for you. Patients who are symptomatic, if your gas diffusion is below 40%, or if there's a significant drop in your vital capacity or your gas diffusion over 6 months, or if you're developing significant desaturation, or a CAT scan shows what we call honeycombing. When you meet these criteria, then your healthcare provider would tendency to refer you to the transplant center, which is in the Mater Hospital. Now, transplantation is not the be all and end all. And if you can see here, these are the survival statistics for people. Oh, go back on that, actually. Let me just see how I go back on my, oh, here we go. Here. These are survival over the space of 10 years for different diseases. And the one in the orange, which is this one, are survival statistics for people who had transplantation for pulmonary fibrosis. And as you can see, over 5 years, 50% or less are still alive. So again, transplantation is, it can be of great benefit in the appropriate patients, but to know that there's an average survival of 5 years. Pulmonary fibrosis prognosis is highly variable, and patients can follow different pathways. More commonly, it tends to be, this is without treatment. It tends to be a slow progressive disease like this over time, and this is in years. And these symptoms, and this is the disease progressing to the point of death. This is when your symptoms start, and this is often when people are diagnosed. Some patients, the disease can progress very rapidly. And this is, again, can be quite refractory to treatment. And other patients slowly progressing and then get exacerbations. When that happens, they have a significant loss of lung function, but then get stabilized with the appropriate treatment and go back on a slow progression again until another exacerbation occurs. So that's why it is very important to try and prevent exacerbations if possible. The average survival without treatment tends to be anywhere from 3 to 5 years. And as I mentioned, 5 to 20% of patients experience a very rapid decline after a period of relative stability. Most common cause of people dying is from respiratory failure and or infection. People are at increased risk of lung cancer, and up to 10% of people with fibrosis of the lung can develop lung cancer. So it is very important to have regular evaluations with your healthcare provider. The prognosis without treatment, as you can see, compared to other cancers, such as skin cancer, prostate cancer, bladder cancer, is obviously much shorter. And so, again, it said this is without treatment. And so not a very good prognosis. This is an example of the prognosis for pulmonary fibrosis compared to other interstitial lung disease, such as non-specific interstitial pneumonia. And this is over a space of 7 years. This is the percentage that are alive. And you can see pulmonary fibrosis has a bad prognosis relative to other diseases if not treated. This is other examples of that. We also talk about exacerbations of pulmonary fibrosis. And these are usually unexplained acute worsening of breathlessness or new development of breathlessness in people with known pulmonary fibrosis. The CAT scan shows a classic picture of a lot of inflammation in the lung superimposed on top of the scarring. Other causes of flare of exacerbations can be infection, pneumothorax, where the lung collapses, heart failure, pulmonary embolus, clots in the lung, or if other drugs they're on can cause drug-induced lung injury. CAT scan is usually performed to help us decide if there's blood clots or if it's all inflammation or infection. And often we'll do bronchoscopy to help us make that distinction. If we do feel it's an exacerbation of the pulmonary fibrosis, then patients will be given high-dose steroids and then maintain those steroids until the exacerbation settles. We also often tend to treat with antibiotics simultaneously. These have been recognized, these exacerbations are an important cause of death in people with only mild to moderate disease, which apparently had been stable and can be very unexpected. Why it happens is poorly understood, though viral infections may act as a trigger. When you do biopsies of people's lung and with the exacerbations, it shows a classic picture of inflammation. The mortality is high, unfortunately, and over 90% of patients pass away within 6 months of discharge. So it is a bad prognostic indicator when someone gets an exacerbation. So the key take-home points is that the prognosis for pulmonary fibrosis is unpredictable. And early diagnosis and appropriate management are vital to maintain quality of life and slow the disease progression because the treatment works. Disease management is crucial for patients with pulmonary fibrosis and includes the antifibrotic therapy, but also pulmonary rehabilitation, managing comorbidities which patients with pulmonary fibrosis are at higher risk of, such as heart failure, coronary artery disease, diabetes, lung cancer, supplemental oxygen if and when needed, social and psychological support, and lung transplantation for patients that meet the criteria. And early referral is encouraged for this because of the delays. And with that, I'll stop and I'll take any questions. Thank you.
Thanks, Aidan. We do have a couple of questions in. One just came in a second ago from Matt. How often should CT scans be carried out on PF patients?
Well, we do not tend to do CT scans regularly. It's not a regular test to do. Now, different healthcare providers will do it in different ways, but in general, it's the evaluating the patient, meeting them, examining them, and lung function tests are the key investigations and measuring the oxygen levels. Now, sometimes X-rays, but rarely will follow-up CAT scans be required.
Okay, we have another one. A PF client who is on pirfenidone has a liver disease and a clot in her eye and is on medication for both. She's wondering, or he or she is wondering, wondering if the medication is interacting with the pirfenidone or as she's having problems with diarrhea.
Yeah, the diarrhea can be a common manifestation with the pirfenidone, and often we'll give patients drugs like Imodium or Lomotil to manage that, as long as we feel the diarrhea is not due to something else, and that'll be very important to assess for that. As regards interacting with other, if she has liver disease, then the decision to have been put on the medication would have been obviously thought about, long and hard before initiating it, and then it would be very important to monitor the liver function tests very, very carefully. And as regards the clot in the eye and being on a blood thinner on that, again, they'd want to make sure that the blood thinner medication that they're on isn't interacting with the drug. And there's a very simple, we have access to databases that look at that and tell us which drugs interact with which. And if their healthcare provider would have done that before initiating the drug.
That's great. And there's a good few questions coming in, some quite long questions coming in. So we're going to get some of the team to answer them throughout even the coffee break as well. But Aidan, thanks for that. I'm going to hand over to Eddie to just keep on time there. Thanks, Aidan, for all your help.
Thank you very much. Take care.
Thanks a million.
Thanks again to Dr. O'Brien anyway. I'll move swiftly along now. Our second speaker is Grania Murphy. And Grania is a senior medical respiratory physiotherapist working at the Mater Hospital for the last 23 years. Grania has previously worked at Guy's and St. Thomas's Hospital Trust in London for a number of years. Grania works mainly with patients with interstitial lung disease and runs a virtual pulmonary rehabilitation class for people with ILD. The title of Grania's presentation is The Benefits of Exercise in Pulmonary Fibrosis and Managing Breathlessness. So with that, I'll hand over to you, Grania.
Thank you, Eddie. And thanks to ILFA as well for inviting me to talk today. Now I'm just going to figure out how to share my screen.
I have your slides here, Grania, if need be.
Okay, should be able to do it.
Yeah, they're coming up now.
Okay, is that all right, everybody?
That's perfect, yeah.
Great, thanks. So my name is Grania. I'm a physio working in the Mater Hospital, and I wanted to talk to you today about the benefits of exercise in pulmonary fibrosis and managing breathlessness. I'm going to go through a little bit about your lungs. Dr. O'Brien spoke extremely well there earlier on about your lungs. I'm going to talk about inactivity, the benefits of activity and exercise, ways to exercise, a little bit about managing breathlessness and energy conservation. So, just pointer here. About your breathing, each time you breathe air in through your nose or mouth, and it goes down your airway, your windpipe or your trachea. And, oops, sorry. And this trachea or windpipe branches into two airways called bronchioles, one into your right lung and one into your left lung. Each of these bronchi, then breaks down into a number of smaller airways called bronchioles. And at the end of these airways, you have small air sacs called alveoli. So at the end of all the little airways here, you have air sacs, alveoli. It's here that the oxygen that we breathe in is transported across the wall of the air sacs and into your bloodstream, and then that's transported around the body. So pulmonary fibrosis is the result of a number of conditions that cause scar tissue to build up in the lungs, and Dr. O'Brien spoke about this earlier on. The scarring happens in the gaps between and around these air sacs or alveoli that I described there earlier on. And the area around the alveoli is called the interstitial space. And the scarring limits the amount of oxygen that gets into the blood. So breathing may feel like hard work, and you can feel breathless from everyday activities like walking. This can lead to inactivity. So what happens if I'm not active? If you do less activity, your muscles are going to become weaker. Weak muscles use more oxygen and are less efficient. You will then feel breathless. You become fearful of activity that makes you breathless. You then avoid those activities that make you breathless, and you do less activity. This is called the cycle of inactivity or the cycle of breathlessness. The good news is that we can break this cycle. So you can break this cycle of inactivity by becoming more active. You can make your muscles stronger, including your breathing muscles, and this will help you feel less out of breath when you do everyday tasks. So you do more activity to help your breathlessness, your muscles will become stronger, your muscles use oxygen more efficiently, you're less breathless and tasks become easier, you feel better, you're more motivated to continue being active, and hence you do more activity to help your breathlessness. And so goes the cycle of the positive cycle of activity. So just to recap, exercise is good, exercise is important. The benefits: it increases muscle strength. Stronger muscles are more efficient at using oxygen and creating energy for everyday activities. It improves breathing and helps with shortness of breath. It improves your general mobility, improves your mood, and helps with bone density, reducing the risk of osteoporosis. So we know the benefits, we know it's important. How do we exercise? The first thing I'd say to you is sit less. This is one of the biggest changes you can make. Try to break up long periods of sitting and increase the number of steps you take every day. Using the ILFA 2000 steps challenge is a good way to start. This is an exercise challenge aimed to motivate you to incorporate an extra 2,000 steps into your daily routine. It was devised by Irene Byrne, a senior physiotherapist in the Mater Hospital, and developed by ILFA. The other way to exercise is join a pulmonary rehabilitation program. If this is offered to you, if there's one in your area, it is a really good thing to do. You can ask your doctor about it. And if you are offered it, I'm just going to tell you a little bit about what is involved in pulmonary rehab. It's a program of exercise and education. It involves an assessment at the beginning and end of the program by usually a physiotherapist or a respiratory nurse specialist. The exercise component should be tailored to meet your own ability and needs. It usually contains a warm-up of some description, strength exercises, aerobic or endurance exercises, and a cool down. And there will be rest periods built in between all the sets of exercises. These programs vary. They can run they can be 8-week programs, 10-week programs. A lot of them are run virtually now. Some may be face-to-face. The education component aims to give you a better understanding of your lung condition and manage your breathlessness better. So I mentioned aerobic and strengthening exercises there, and I wanted to just explain these a little better. Aerobic or endurance activity, these exercises work your heart and lungs. So they're the type of activities that include walking, dancing, gardening, swimming, cycling. When you're doing these aerobic exercises, you should aim to get moderately out of breath to ensure that you're working at the right level. So you can use a Borg scale and a talk test to check that you're working at the right level, and I'll show you these in a minute. The general guide is every week to try to do at least 150 minutes of aerobic activities. Sounds like a lot. When you break it down, 30 minutes, 5 days a week. You can break this down again into 10-minute sessions throughout the day. You should also try and incorporate some form of strengthening activity. Strengthening exercises are exercises aimed to increase the strength of your muscles. So aim to do these at least twice a week. Strengthening exercises you will learn if you attend a pulmonary rehab program or the ILFA exercise program online, which runs twice a week. Or you can ask your physiotherapist to give you some strength exercises. I will show you a few just in a few slides. This is the Borg scale that I mentioned. It's a subjective scale of breathlessness from 0 to 10, where you decide how breathless you are. You measure how breathless you are. So you should aim to be moderately to somewhat severely breathless when you're doing your aerobic activities. Most benefit out of it. If you are getting up to a 5, 6, 7 on the Borg scale, severe breathlessness to very severe, you're just doing a little bit too much, going a little bit too fast, walked a bit too far. So just pare it back a little bit and try and keep your breathlessness to a moderate to somewhat severe. You can also use the talk test to gauge how breathless, or to gauge what level you should be working at. During aerobic activity, a quick way to check if you're working at the right level is to say out loud, "This activity is doing me good." If you can say the sentence with 2 or 3 stops for breath, you are working at a moderate intensity. This is what you're aiming for. If you can say the sentence continuously without stopping, you need to increase the pace a little, increase the intensity. If you can't speak or can't say more than 1 word at a time, you're doing too much. Slow down. So recap of exercise in general: sit less, increase your steps daily, join a pulmonary rehabilitation program where you can, aim to do some form of aerobic activity, walking, cycling, gardening, 20 to 30 minutes a day, 5 days a week. Aim to do some strength exercises twice a week. So just for those of you who haven't exercised before, who may not know where to start, I'm going to just give you a couple of tips here on where to start. At home, if you're going upstairs to get something, go up and down the bottom step twice, then continue up the stairs. This will mean that you're doing 14 steps instead of 12 in a flight of 12. The stepping on stairs, really good strength exercise for your legs, along with being aerobic. When you stand up from a chair to go and get something, sit down again and stand up a second time. You're doubling your effort, you're using your muscles twice as much by doing this simple change. When you're watching TV, straighten your legs one at a time, out in front of you, bend and straighten your elbows, reach one hand up to the ceiling, reach the other hand up to the ceiling. All of these are using your muscles. Repeat them a few times. You're doing really well with your reaches and your bend and straightening of your elbows. Use some weights, tins of beans, small bottles of water, and do your elbow bends and your arm lifts that way. When you're standing at the sink or the kitchen counter, go up on your toes and back down on your heels 3 to 5 times. All of these help. A little bit just about managing your breathlessness. I mentioned the Borg scale earlier on. Use that to assess your breathlessness. You can also use the stall technique and fans, and I'll just explain these a little bit now. The stall technique, this is a card developed to be, it should be kept in your wallet or your purse or your bag. And if you experience an episode of worsening breathlessness, you can take this card out and read the stall technique to help with that breathlessness. You can also give the card to your carer or somebody who may be with you, and they can talk you through it. It's S, stop what you're doing. T, try to remain calm and turn up your oxygen if you have oxygen. A, assume a comfortable position. Sit down, lean against a wall. L, let your imagination take you to a safe place. Imagine yourself there relaxing. L, let your breathing return to normal. Really useful technique. Fans, people have found beneficial as well, and they're easy to use and portable. Safe and inexpensive for a small hand fan. Hold it about 6 inches from your face. Use it as often and as long as you want. And lastly, just to talk about saving energy and saving your energy for the things that you really want to do. You can learn to use less energy as you go about your daily life. It's important to stay active, but also to pace yourself. Adopting a slower, easier pace helps you save energy. So, conserving or saving energy, prioritize your activities. What's the most important thing you want to do that day? Save your energy for that. And then the other things that you're doing, try and slow the pace or sit down. I'll explain this in a minute. Plan and space the activities. So if you had to do the gardening and the hoovering this week, split them up, put them on separate days. You want to do your exercise class twice a week, but you want to visit your friends as well, again, spread them out. Try not to do the exercise class the same days as going to visit your friends. Pace yourself. Take regular rests. Do an activity, sit down for half an hour, rest. Go on to the next activity. Try and get some relaxation time for yourself. Find a quiet corner, read a book, turn on some music. Use seats where possible. A seat in your shower, a seat in the kitchen, preparing the dinner. Sit down when you're ironing, sit at the bathroom sink if you're brushing your teeth, washing your face. Use shopping trolleys, rollators, carrying carts. All of these help save your energy for the things that you really want to do. So in summary, exercise should be a part of your life. Try to exercise every day. Exercise is as important as your medications. Never waste energy that could be used for better things. Thank you, everybody.
Thank you, Gornia. Mainly the questions that's been coming in have been some personal questions, and we will get some of the team to answer them throughout the session or after the webinar itself. No, I think you got off lightly, Grania.
Great. Thank you.
No difficult questions. So I'm going to hand over to Eddie.
Thank you, everybody.
Thank you, Grania. Very nice talk indeed. Our next speaker is Maria Love. Maria has been a great friend to ILFA over the years. Maria is end-of-life care coordinator in the Mater Misericordiae Hospital, and her role focuses on palliative care, end-of-life care, and supporting quality improvements for patients, families, and staff. Maria's background is in medical social work, and she has worked as a senior work practitioner for the National Lung Transplant Service at the Mater Hospital. Maria is passionate about empowering others to live well with palliative and end-of-life care, biopsychosocial approaches to healthcare and education. Maria's presentation is called Palliative Care and Coping with Serious Illness. So Maria, I'll leave it with you now. Thank you.
Great, thank you, Eddie, and thank you to everybody at ILFA for inviting me to speak this morning. Sorry, I need to share my screen. Let me just do this. There we go. Okay, wonderful. Right, so thank you, Eddie, for that introduction. So my talk today is on palliative care and coping with serious illness. My name is Maria Love. I'm in the Mater for a good number of years now, and I'm currently in the post of the end-of-life care coordinator. And I suppose what that means really is that I focus on improvements around end-of-life care. So helping, I suppose, patients and families and staff cope better, putting different things in place to help them cope better with that journey. And for me, really, palliative care, end-of-life care, it is a continuum of care. It's not just about, kind of the last days, the last weeks either. And I think many people certainly, when you say to them palliative care, they get frightened, and that's not surprising. Sorry, I think something's happening here. So I suppose people do get frightened when they hear palliative care. So today is really just about a very gentle introduction to palliative care, what it is, who it's for, where you might be able to get it. And certainly I would see palliative care as a suite of different approaches that you can use to support yourself, to help yourself and your family to cope better. And I know Dr. O'Brien and Grania spoke, about the different approaches, the medical approaches, the pulmonary rehab, the getting up and moving, and how all of these things can help you. So again, this is just maybe another way just to consider. So I suppose in terms of the background to my talk today, some of you may recall that in 2018, ILFA conducted research into the palliative care needs of people living with pulmonary fibrosis. And many of you here today on, attending these talks might have been involved with that research. So again, that was a mix of different people. So it was people living with pulmonary fibrosis, family members, healthcare professionals, people involved, I think it was a member of the clergy, people involved in voluntary organisations, so on and so forth. And really it was to try and understand what are the needs and the different aspects of palliative care and living with a disease that people might need support with. So this was the first research of its kind in an Irish population and was published in October 2021, so congratulations to all involved. And I suppose there were discussions on various themes which included practical, psychological, legal, transplant, exacerbation, palliative care and end-of-life care issues on that kind of research day. Again, another background, something I looked at in pulling this talk together was the stakeholder survey that ILFA conducted in early 2020. And what was interesting to me, and I suppose some of you might notice the Think Ahead document there on the screen. In the section, I suppose, that focused on treatment options in the event of becoming unwell, a lot of people hadn't, or perhaps didn't want to think about, well, what happens if I do get sick? What happens in the future? And quite a number of people didn't have those conversations with family members, or maybe they had them with healthcare staff, you know. And again, I think we all appreciate nobody wants to consider our mortality or how frail or fragile we all are. So, you know, I suppose it is very challenging to have those conversations. The Think Ahead document you can see there on the screen, that is, I suppose, one way that the Irish Hospice Foundation have come up of maybe approaching a way to look and record, you know, I suppose some of the questions and the answers you might want to think about. So these, you know, and again, I don't expect you to look at the screen, you know, but I suppose these were just a variety of the different issues that came up during the research. And I suppose what these slides kind of really prove to me, and these are not by any means everything that came up, you know, there are more. What these slides say to me is that living with pulmonary fibrosis, caring for somebody with pulmonary fibrosis, it's very complex. And I think it depends on what stage of the disease you're in as well, how you're feeling, you know, a lot of very individual factors as well. So I suppose it is a complex thing, and may need different strategies, I suppose, in terms of coping, you know, depending on where you're at, you know, but again, everybody is different. And I know I often show this slide when I'm doing presentations. This is the biopsychosocial model of disease. And I suppose the reason I like showing this particular image is that it kind of gives us maybe an indication of how holistic approaches to dealing with health issues can help us understand them better. So there's that great quote there at the bottom of the screen. The medical support keeps me alive, but it is the psychological and the social support that enables me to live. So again, and I know Gráinne kind of touched on this as well, just in terms of the cycle of inactivity. You know, we may be living with a disease, but it does impact different parts of our lives as well. So the psychological, the social, the spiritual aspects as well, our relationships, the financial end of our lives, the legal side of our lives as well. So understanding how we cope can help us maybe look at what can help us as well. So it can kind of help us find solutions, I suppose. And again, if we find that, look, we may need to develop new skills, we may need help or support, in a certain area, then we can look at how we develop that, you know, and we hear a lot about resilience as well, you know, particularly over COVID. And resilience and coping skills are something that can be learnt. And again, Gráinne, I think already has touched upon the vicious cycle versus the virtuous cycle. So that's just displayed in the image there. So going back to the research that ILFA conducted, so what does this research tell us about the palliative care needs of people living with pulmonary fibrosis? So what was already known was that palliative care needs in advanced interstitial or fibrotic lung disease, they're documented in research. So there is some research out there in relation to this. But we also know that the timeliness of palliative care in PF is suboptimal. So what that means is maybe people are not getting it when they need it or at the right time, or maybe the teams are not referring in time, or maybe it's you know, a lastminute.com, you know, type of referral. So what are the findings of this research? So I suppose this research kind of tells us that palliative care is fundamental in all stages of illness, and it is required from diagnosis onwards. So I guess everybody is very different, you know, and certainly palliative care might be for you, it may not be for you. You know, I think it is dependent on various factors. But I suppose the significance of these findings are that certainly palliative care may be a support, and it may address some of the support needs of people living with PF and their carers as well. So certainly a wonderful piece of research, and I'd kind of recommend everybody read it. So what is palliative care? We've talked a lot about it, so I'm going to read out a definition to you. So the World Health Organization defines palliative care as follows. Palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification, impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. And so I suppose maybe reflecting back to the biopsychosocial model that I showed earlier on, this is perhaps just one, it's a holistic way maybe of looking at the person and their family, and it's one approach that can help people to live better, to have maybe improved quality of life. And I know Dr. O'Brien mentioned earlier on about palliative care and maybe the interventions in terms of breathlessness. So again, anybody living with PF knows how debilitating that can be. So what is palliative care? I suppose we all know coping with a serious illness is difficult for everybody involved. And as per the definition I've just read out, it is an approach to care that aims to improve the quality of life and relieve suffering. So it looks at the person and the family holistically, and it works with the person and the family to help them optimize their quality of life. So this could be a focus on the physical symptoms, or this could be providing maybe practical or emotional supports, and this could be in the hospital, or this could be in the home. And I suppose palliative care and a palliative care approach can be provided by any health or social care professional. But as we'll see in the next slide, there's kind of different levels, you know. And I suppose palliative care would most commonly be provided by, generalist, healthcare professionals. But again, there is a specialist palliative care team, and I suppose that's probably what most people think about when they think about palliative care, is maybe a community palliative care team or their local hospice, or perhaps family member were under palliative care before. So who can get it? Who can get specialist palliative care then? So, and again, I think Dr. O'Brien touched on this earlier on. So specialist palliative care, I think traditionally the perception was it was only for people suffering with cancer. And maybe in the early days that was the case. But now it has expanded to include, I suppose, advanced heart failure, lung disease, other neurological conditions, and is very much on a case-by-case, basis. So what happens is, I suppose, the specialist palliative care team may be consulted when the primary care team or when your GP feel that you might need a little bit more help. They might need a little bit more help just in terms of managing symptoms. Or you might feel that you need that as well, and again, I think Ronya spoke about, the importance, and Dr. Bryan about the importance of pulmonary rehab, and I'm aware at the moment that the local hospice to the matter is St. Francis Hospice, and at the moment they are running a rehab class with an OT and a physio. So again, it's accessing wherever you can access, these programs to help your quality of life. So again, specialist palliative care may be provided in partnership with hospital-based treatments, or it could be a dip-in and a dip-out approach. And that's often what I see. So you might need palliative care for a few weeks or for a few months, maybe to optimize management of breathlessness. But then if you steady out and you plateau and you're doing fairly well and you feel you don't need that kind of support, then they might kind of retreat a little bit and then jump back in when you need it. So I always say to, I suppose any of my patients I've been working with in the past, certainly consider it. Take it if you feel you need it and you would benefit from it, and if it's available, of course. I suppose the other aspect of specialist palliative care is then when, maybe towards the end, when somebody is very, very unwell and the patient and the family feel that the time has come where the focus should be just on comfort care alone. So again, people can get this specialist palliative care. It could be in the home, it could be in hospice. Again, that worked out very much on an individual basis. So again, everything is very much an individual assessment, and you have to consent to be referred to specialist palliative care as well. So again, it's something you would have to discuss with your GP or with your hospital team and agree to do. So hopefully nobody's going to jump it on you. So where do you get palliative care? Well, as we said, look, every healthcare professional should be able to provide a palliative care approach. Typically where we see palliative care is maybe the GP, maybe inpatient hospital teams as well, or maybe the community palliative care teams. However, the one caveat that I suppose I will put in, or will say, is that palliative care teams, they do differ across the country. And what I mean by this is that different areas have different levels of resourcing. Not every county in Ireland has a hospice, unfortunately. So again, I think it's about finding out where your local team is and what the access is. You know, usually GP referral can get you access or referral to them. However, what they might be able to do for you, or how long or when and where they may be able to work with you, can differ from team to team. But I suppose typical places you might get PAL care is as an inpatient in hospital, or by the community palliative care team. However, it's kind of good to know, and again, this differs from hospice to hospice. Some hospices have daycare, and I think I was over in St. Francis's there recently, and I met some of their complementary therapists and their chaplains, and my God, they offer, and hairdressers. I was very impressed. So they certainly offer a great kind of daycare program, and that's when somebody comes in just for the day, and then they might be seen by the doctor, by the nurse, by whoever on the team they need to see, and get some of the benefits as well, the nice stuff as well. As I mentioned already, there are rehab programs running in some, but not all hospices. Sometimes people who are under specialist palliative care, they might be brought into the hospice, maybe for a few days. Maybe if, for example, your medications might need a little bit of tweaking. So again, that can be an option for some people. And then I guess there's usually bereavement support. So when somebody does die, unfortunately, usually there's a social work department in most of the hospices that can do that follow-up bereavement support for yourself or for family members, So I suppose it's very much, as I said, individual, depending on the hospice. Again, a lot of what we're familiar with is that the community palliative care team. So I guess there's a small number of hospice beds, as we probably all know. And most people do want to be at home towards the end of their life, and certainly most people do want to die at home as well. I think in the recent research, 74% of people have said that they wanted to die at home. So this is where, again, where appropriate, the palliative care team may be able to support you to do that. Now I'll quickly run through this. These are some pictures of our local hospices here. So the top one is one of the day rooms in St. Francis's. So look, I'm based in Dublin, so my apologies. I haven't put other pictures up. The bottom picture here is the hospice out in Blanchardstown. So again, they all have different facilities, different services. So I suppose the traditional picture of a hospice was very much, look, it's someplace you go at the end of life, and that has changed as I've explained. So certainly it might be good to have a look and see what's available in your local area as well. So who's on the team? As I said, very much dependent on the service, dependent on the local resourcing and staffing levels. I suppose typically on the community palliative care team, so this is the team that would go to you in your home. That is normally made up of consultants, of other doctors, of nurses, and medical social workers as well. And again, how much input you might need, it does vary. I suppose speaking from personal experience as well, we had the community palliative care team when one of my family was at home. And again, they were great. They just came when we needed them, and we were very lucky and hugely supportive as well. I suppose in terms of the hospice team then, there can be a larger team in the hospice. So this could include occupational therapists, physiotherapists, chaplains, complementary therapists, hairdressers, so on and so forth, volunteers, for example. But again, and dietitians as well. So again, very much dependent on where you are. So how do you get referred to palliative care? You talk to your GP, you talk to your healthcare team. Now again, I suppose palliative care, when is the right time? And that is very different for everybody. So this is something to think about, maybe talk to your family about as well, and have a chat with your healthcare team. And certainly some doctors might not feel, well, look, now is not the time, but you can bring that conversation up again, And where can you get more information? Because I know this is just a very brief touching upon just a general overview of what PAL care is. There's a lot of information out there. I would direct everybody towards the Irish Hospice Foundation. If you want to know more about Think Ahead, if you want to know more about local resources, etc. Your local hospice, your local community, palliative care team. Lots of information there. The All Ireland Institute of Hospice and Palliative Care, always a bit of a mouthful. That again has a lot of information about where you can get local services or find out about them. And then we have a short video up on the Mater Hospital. This is one we created recently enough to kind of explain to patients and families, because there is that fear there, about what palliative care is and what it might mean to you as well. St. Francis and Our Lady's Hospice in Harold's Cross, there are local hospices here to the Mater, so that's why I've included them. But you should be able to get information about where your local palliative care service is based from the All Ireland Institute website. The other thing I suppose that is important to talk about is thinking about your future. And look, some of us are just not comfortable going there, talking about it at all. But if you are comfortable talking about, or looking at your future, I would certainly urge you to have a look at the Irish Hospice Foundation, the I Want to Think Ahead. And that will give you some maybe guidelines and conversation openers and questions and some resources to help you think about, well, look, what legal issues do I need to look at? Are there any financial issues? And if there are financial issues, the website there, Citizens Information or MABS, they're again both, sorry, that's on the next page, the MABS one, they're really good places to look as well. So what else can I do to help myself? And as I've said, palliative care is just one of those approaches, one within a group of approaches that can help you cope better. And I'm conscious as well that Patricia is giving a talk later on, living well with pulmonary fibrosis. So my apologies if we've overlapped a wee bit. And I know I put these slides up at a previous presentation before, but I think it's good to consider all of the different options that you might have. So I have pulmonary fibrosis. How can I help myself? I think, look, everybody needs to be an active participant in their own healthcare, without question. So learning about pulmonary fibrosis, even being on this presentation on this patient information day today is a great step. Get reliable information, write it down. When you're going to your doctor, you're going to your GP, whoever you go in with a list of questions, and certainly write down things afterwards or jot down notes or keep a journal or a diary. Again, it's just to kind of stay on top of things. Focus on your quality of life. So you may not be able to change the diagnosis, but certainly you can learn new ways to cope. And that can be difficult, absolutely, by all means. But again, change is your choice. It's a choice for all of us. And you may need support, with that. So if you do need support or advice, this is where talking to your healthcare team, your GP, looking at what is available via the HSC as well, your primary care team, for example. Again, Dr. O'Brien, Grania have, focused on the importance of exercise, physical activity, really important. And exercise and, I suppose, well-being and mental health, they are linked from the research. Again, being socially active, online or in person or online even, the other way around. Continuing your hobbies, joining a support group like ILFA, taking up new hobbies if you're not able to do what you did previously. Again, social isolation can have a hugely negative impact on mental and physical health, and we've seen how they are interlinked. Again, establish a good daily routine you stick to, and something that you can stick to, and something that is flexible if you need it to be flexible. So it is about being realistic. What are you able to manage? Grania talked about energy conservation even. So again, can you break down tasks to make things easier on yourself, rather than getting frustrated that you can't actually do them? Again, think about the practical and the financial issues. Think about planning for the future. Are there issues that you do need to look at? And again, it can be challenging to think about these things, but you don't have to do this all at once. Break it down into smaller steps. I think honestly about the emotional impact of living with pulmonary fibrosis, it can be huge. So again, asking for help, maybe being honest with yourself if you do need help. None of us like to ask for help, but we do need it. And remember that you're somebody who's suffering with an illness. It's not your complete identity. So you have to live, you have to have fun, you have to get on as best you can. I know we're all restricted at the moment with the pandemic, but again, it's it's trying to stay, engaged and active and having fun in your own life as well. Again, carers, and there are many carers, no doubt, attending today. So again, carers are so important in terms of supporting the person with pulmonary fibrosis, and they're often, maybe overlooked, and there certainly is limited research into what is the best way to support carers. Everything I've said in the previous slide also holds true for carers. So looking after yourself mentally and physically, getting information, getting support, all really important. I think it is important as well to recognise that caring people do get burnt out. It can put a strain on your relationship. It can affect you in many ways. So again, it's about, I suppose, trying to ask for support if you can get your hands on it. Identifying that you need to, I suppose, retain your own identity as well and your own interests, and have some time for yourself as well. So that's important. So again, it's a very challenging thing, I think, to get the balance right between, allowing somebody to be independent and not smothering them with love, or kindness as well. So look, there's no, I suppose, magic level, or magic wand for that. So I guess trying to look after yourself and the person with pulmonary fibrosis, it is challenging, absolutely. In terms of a healthcare professional as well, now I'm not going to go into this into too much detail, but I think what the research will say is empathy and compassion are really important when dealing with anybody suffering with any disease, and certainly towards the end of life. Education is absolutely critical as well. Clear verbal information, written information, online information, showing pictures again. A lot of people might say, oh, I feel really well, so why are you telling me my lungs are bad? So I think sometimes when you see the image, and I know Dr. O'Brien showed an image there of the honeycombing of the lungs, and that's very powerful, I think, when you see that. Important as well as a healthcare professional to recognise the role, and the really important role of the carer as well, because it has such a huge impact on how the person copes. Again, avoiding medical jargon, I think we all know that one. And I suppose when delivering bad news as well, I think any of us, if we get bad news, it can be very hard. It can be very shocking, and people can't take in information when they're shocked, because their brains go off and they're kind of jumping ahead and thinking of worst case scenarios and everything, God knows what. So again, I think getting that information, revisiting information, if you're delivering a diagnosis or if there's disease progression, again, it's very important, and maybe recapping that information at appointments. Again, we've talked about this already, comprehensive symptom management. Dr. O'Brien, growing in our talk as well, looked at all of the different ways, and certainly palliative care is perhaps an approach that might support you in symptom management as well. Again, just for healthcare professionals, yes, anxiety, depression can exist, but not necessarily so. But it's just to open that conversation, and a one size fits all does not work. So I think we really do need to look at the person as an individual, their family, and all of these component parts around the person, and really offer that kind of person-centered approach. And I suppose very important thing to remember, Rome wasn't built in a day. So look, we're giving you lots of great advice, I hope, today, but it's, you're not going to be able to do everything in one go. So certainly look at, right, well, what can I do today? What do I need to change? Is there any small thing I can do? So it's baby steps, it's small steps. It's not trying to take on everything, going, right, I'm going to change my entire life. I need to do this, this, and this, and this. Break it down into small steps. I'm a great person for lists, so that's the way I work. In terms of finding professional support then, locally, GP, public health nurse, primary care team. If you go to the HSE website, you will find information for your local team. Your GP should have it anyway. In terms of the hospital then, many of you are already linked in with possibly a hospital team, consultant and IPF centre. So again, asking those questions of the team that you meet in the hospital. Counselling is available via your GP and your primary care services with a medical card. Again, I will say this can differ from place to place as well. If you are considering a private counsellor, do ensure that they are regulated by a professional body as well. Psychiatry services can be available. Palliative care teams, again, may be able to offer that, be it symptom management from the physical perspective or the emotional perspective. They may be able to support you with issues that arise. And certainly joining support groups, attending education days is really important as well. Financial social welfare information, always a worry, I think, for people, naturally enough. Citizens Information are a government-funded organisation. Most people are aware of them already. They have a phone, they have online services, they have a website. So again, if you do need information, go to Citizens Information in whichever way suits. And MABS is another fantastic organisation in terms of financial supports. And again, getting reliable information from reputable sources, very, very important. I always say to people, just don't go on to Dr. Google, because God only knows what you're going to find, and you'll find the worst things. So finding information from reputable sources, really important. So look, that is me finished up. So as I said, just a few take-home questions to consider. How can you help yourself cope better? Is palliative care, I suppose, something that you might consider, you might feel is appropriate? Maybe it's not, maybe it is. Do you need to look ahead into your future? Do you need to start planning now for maybe some of the financial issues or the possible legal issues in the future? So how do you do that? Who can help you? And what resources can you get? So important to identify all of those things. And what's really important now as well, because I think it's important to be grateful for what we have, and all of us have some good things. Life is never just about black or white. I think it's about a combination of both. So it's remembering what we're grateful for right now as well, and enjoying. I think, yeah, the fun aspect has been missing them maybe a little bit over the last couple of years, but again, it's trying to enjoy the little things. I think that's really, really important. And thank you very much for listening. So I'm going to stop sharing now, I think, yes. And there we go. Thank you.
That's great. Thank you so much, Maria. A lot in that presentation. Some individual questions which we'll send on to you privately, and I'll let you answer them. Just conscious of time, so I think Eddie will go for
it. I think we should have that comfort break at this point, and we'll say approximately 5 minutes. So if I say 12:30, we should resume. Thanks again, Maria. Welcome back, everybody. Our next speaker is Patricia Jones, and Patricia is a respiratory clinical nurse specialist at St. Vincent's University Hospital. Patricia has recently joined our committee, and we are delighted to have her to speak at today's event. Patricia's presentation is entitled Living Well with IPF. So if I can hand over to you, Patricia, now. Thanks a million.
So as Eddie mentioned, I'm Trish Jones, a respiratory clinical nurse specialist in St. Vincent's University Hospital. And I've been working in respiratory for over 20 years with a professional interest in interstitial lung disease and caring for patients and their families and carers with helping them to live with pulmonary fibrosis. So I'm going to just continue on with the talk, Living Well with Pulmonary Fibrosis. And just a bit of a recap, because I know some of the previous speakers have explained a lot of this. So pulmonary fibrosis is a disease where there is scarring of the lungs, which makes it difficult to breathe. Pulmonary fibrosis is a specific chronic form of progressive fibrosing interstitial pneumonia of unknown cause, occurring primarily in the older adult, and it affects the lungs primarily. It's a restrictive lung disease. And while you can't cure pulmonary fibrosis, there are a variety of things that you can do to help you maintain a good quality of life and stay healthy as possible. So as Dr. O'Brien mentioned earlier, about half of our patients with pulmonary fibrosis have a disease that progresses gradually and slowly, while others appear to experience periods of relative stability, which is interrupted by unpredicted acute exacerbations, and these exacerbations can accelerate the progression of the disease. So we try to avoid exacerbations at all costs. So idiopathic pulmonary fibrosis symptoms, we're going to talk about a few of these and ways we can help to manage them to help us live better with pulmonary fibrosis. So a lot of you have experienced these: breathlessness, cough, fatigue, weight loss or gain, gastric esophageal reflux disease or reduced exercise tolerance and capacity, low oxygen levels, which occur most commonly on exertion but can also occur at rest and during sleep, anxiety and depression, and fear. So living well with pulmonary fibrosis means that we need to adopt and maintain a healthy lifestyle and behavior in order to improve our quality of life. And there are things you can do to help you live better with this disease. And ideally, in collaboration with your healthcare providers and your healthcare professionals, you devise an individualized self-management program. And in devising this program, you can learn and develop skills to adopt new healthy lifestyle behaviors and changes. So even with a chronic disease like idiopathic pulmonary fibrosis, you can still live an active and fulfilling life. So knowing your disease and taking charge of it is on a daily basis will help you to have a better quality of life. So first of all, we need to define what health is and the changes that we need to make in our lifestyle first to define what health and well-being mean to you. So health is a state of physical, social, and psychological well-being, and having the ability and the skills to cope with the physical, psychological, and social stressors that we encounter on a daily basis. So when you've defined what health means to you, you then set realistic goals and looking at ways that you can change your behavior in order to meet these goals. So having had a decision made for you, what health means to you, discuss with your healthcare provider and your healthcare professional what matters to you, what you would like to do, and concentrate on things that you enjoy doing. And this will be part of your program, trying to do these better, or maybe you haven't been able to do them and you want to be able to achieve them now. And slow, steady, as Maria mentioned, Rome isn't built in a day, and you can set realistic goals. But the important thing when you set these goals is you discuss them with your healthcare provider, regularly kind of looking for feedback on how well you're achieving certain goals, and you maybe have to readdress these goals as you go on. So areas that we're going to consider to help you live well with your pulmonary fibrosis: maintaining a healthy weight and eating well, staying physically active, protecting your lungs, managing your symptoms, coping with stress and emotions, and preventing and managing exacerbations. I know we've covered a few of these with Aidan, Grania, and Maria, but we're just going to do a little recap on some. So first of all, looking at weight management, and the important thing is that you have to maintain a good, healthy weight. Being underweight or being overweight isn't good in pulmonary fibrosis. So we generally look at your body mass index, which is organized by measuring your weight and divided by your height in meters squared. So ideally, you should be between 18.5 and 25, your body mass index. So just to look at how overweight or being underweight can affect you in pulmonary fibrosis. I'm not sure actually if you're seeing the being underweight section on my screen, or are you actually seeing Annette and Eddie? I don't know, can you tell me that, Justin? I'm not sure if it's covering some of the slides there.
No, we can see them all. Yeah, we can see.
You can see them all. Okay, no, so it's just me then. Sorry. So being overweight adds to the work of breathing due to increased workload. So you can imagine, obviously, if you're overweight, it's harder for your muscles to work against your chest wall if you're overweight, and this increases shortness of breath. It's also you're carrying more weight around, so this hinders your exercise capacity and also your exercise tolerance. So being underweight adds to the work of breathing also, because your muscles and your inspiratory muscles, the muscles we use to breathe, are weakened. So you can't take good inspiratory efforts. Also, if you're underweight, your limbs are weakened due to poor muscle mass. This affects your mobility and also your exercise capacity. So let's look at a healthy, balanced diet. So your goal setting here would be to achieve a good body weight and maintain this body weight through a balanced, nutritious diet. So the benefits of a balanced diet is that you store energy, including the energy you need to breathe. So we all burn off a little bit of what we eat just by breathing. I mean, people that don't have underlying lung conditions, we probably burn off less than 3% of what we eat. But obviously, when your work of breathing is a little harder, if you have an underlying lung condition, you will burn off a little bit more of what you, the energy that you get from the food that you eat. So it's important to have a good balanced diet. Balanced diet will also improve your quality of life. It improves your muscle strength and therefore your physical capacity and your exercise tolerance. And it helps to prevent infections by promoting a strong immune system. So what can you do to maintain a good, healthy diet? So small, frequent meals is what we would encourage, because you're trying to avoid sluggishness, eating heavy meals, and also bloated feelings, which can increase your breathlessness. So we would encourage 3 meals a day and 2 to 3 snacks a day, if at all possible. Ideally, don't wait to get hungry. Try to establish a regular pattern of eating. Eat more slowly, take small bites, and deep breathing while you're chewing your food. Take deep breaths when you're chewing your food. Soft, moist foods might be easier to chew and swallow also. It's important that if you have phlegm or sputum, that you clear your airways a good hour before your meals. And try drinking liquids at the end of a meal as opposed to during the meal, because liquids can fill you up and then you won't be able to get the nutrition into you. We would also advise that you eat while sitting up. This causes less pressure on your lungs. And have your meals at least after your meals, say sitting up for at least 30 minutes after you're finished. So a healthy plate, which for those of us that love our greens, half of it should be filled with vegetables. And then the next quarter should be meat and a substitute such as chicken or fish. And another quarter should contain your grains or starches, such as your potatoes, your carbohydrates, your rice and your pasta. You should complete your meal with a dairy product, be it yogurt, a glass of milk, or a substitute, a similar substitute. And if you're still feeling hungry, then some fruit to finish your meal. So strategies for eating well: rest and relax before a meal, plan your meals ahead of time, and select meals that don't require prolonged standing to prepare. Maybe have some of your family members prepare the meals for you, and you can have these kept stored in your fridge or freezer, and they can be used as standby meals so that you can just heat them as required. You can also inquire as to whether you would be entitled to Meals on Wheels, and you can get this information through your local health centre, through your public health nurse. Managing dry mouth is very important, and this can be done by stimulating saliva within your mouth by sucking on boiled sweets, and also by using biogels. Ensuring you have well-fitted dentures is important. Avoiding gassy foods, foods that produce gas also, just because this can lead to bloating. Again, as I said, we're trying to minimize breathlessness. So then the next topic we're just going to look at is preventative healthcare and protecting your lungs. So the first most important thing, if any of you would smoke, would be smoking cessation. And as you can see on this graph, I know it mightn't project too clearly, but it's never too late to stop smoking. The benefits will be seen in your physical health as well as in your lung function here. You can see what Dr. Aidan O'Brien mentioned. One of the things that we measure is your forced expiratory volume in the first second and your forced vital capacity. And this actually improves once you stop smoking. There are aids to smoking cessation also. So local motivational smoking cessation support groups, which are often advertised in your GP practices. Get a quit buddy to help you stop smoking. GP can also prescribe you nicotine replacement therapy, and there are lots of different choices to choose from, so that ones that will suit you and any other underlying conditions that you may have. When you're trying to stop smoking, remember the 4 Ds: delay, distract, drink, and that's water, and deep breathe. The other things that you can do to help protect your lungs is get your flu vaccine. This should be given annually, either in your GP practice or in your pharmacy. You should also get the pneumococcal vaccine. And if you're under 65 years of age, you usually would get 2 doses of the pneumococcal vaccine 5 years apart. Over 65, usually 1 dose is enough, no matter how immunocompromised you are. Also, getting your COVID-19 vaccine will help protect you against coronavirus. Avoiding infected persons and observe good respiratory hygiene. And we've all seen a lot of this over the last 18 to 20 months. But we also understand now the importance of good respiratory etiquette and hygiene to protect ourselves and our lungs. Avoid irritants and anything that triggers or induces a cough for you. And discuss with your healthcare provider screening for gastric esophageal reflux disease, which I know has been mentioned a lot today, but it's a very important factor and very simple thing that can be managed by medication and altering the position of your bed or position of your pillows in your bed. So it's important to discuss this with your healthcare professional. Other comorbidities as well, in order to protect your lungs if you suffer from obstructive sleep apnea, or heart disease, or thromboembolic disease such as blood clots, and these can develop clots in your lungs. All these can need to be monitored to protect your lungs. The other most important thing as well is for you to recognize acute exacerbations, the symptoms of it, and seeking medical advice and early review. So staying physically active, and I know Grania has spoken in detail about this, but again, just as part of your self-management program, we'll just have a look at the goal for staying physically active is to improve and maintain your functional capacities and your exercise tolerance. So by staying physically active, you reduce your shortness of breath, and this also you also increase your muscle mass and helps maintain bone mass, which is really important to help reduce the risks of bone fractures. You also improve your functional abilities and your exercise tolerance. You improve your mood by being out, by being sociable and active, interacting with others. You also improve your sleep and quality of life being physically active. As mentioned earlier, Grania said 30 minutes a day of physical activity is recommended. This doesn't have to be running or anything like that, even walking if it's sufficient, as long as you're physically active and it's aerobic. You should have your fitness level evaluated by your doctor and your physiotherapist or your physiotherapist before starting an exercise program. So as previously mentioned also, ILFA have their 2,000 steps a day challenge walking pack. And this is a great pack which consists of your pedometer, so you can help to count your steps. And also when you're setting your goals for walking, as before mentioned there is a diary that you can have which records your steps each day, and you can see the improvements and you get the feedback as each day, you'll build up your strength and ability and your steps. It also helps you, gives you advice on getting moving with your steps each day. ILFA also have their exercise DVD for lung fibrosis patients, and this includes exercises in a sitting position for those of you that would find it difficult to be active. And along with these DVDs, as I think might have been mentioned by Maria as well and Grania, there are exercise programs online, and the Singing for Health program, which was commenced last year, has been very, very well received, and they're very helpful. And you can register for these programs through the ILFA website. So then we're just going to talk a little bit about managing your symptoms, and I'm going to look at breathlessness and cough and a little bit about the fatigue and gastric esophageal reflux disease. And I know Grania tipped on breathlessness management a little bit, but just to recap on it, we first need to consider and treat other causes of your breathlessness. So not only are we looking at you as having pulmonary fibrosis, but some people might have comorbidities that Dr. O'Brien mentioned, such as chronic obstructive pulmonary disease, emphysema, heart failure, infection, or pulmonary embolism. And these might be causes of your breathlessness, and you need to discuss these with your healthcare provider, your GP, or your consultant to ensure that they are being fully managed. Your physiotherapist may teach you positions of ease, such as leaning over a table so that you can expand your lungs better to try and help with your breathing. Also may discuss leaning against a wall when you're walking. This helps to minimize your breathlessness. Pacing is really important. And like all of us, even if you have pulmonary fibrosis, we all want to get to a particular place as quickly as possible. And that's not always the best thing. Remember, slow and steady is much better. I know patients with pulmonary fibrosis, they're no different, but they are a bit more fearful of becoming breathless. So when you don't have issues with your lungs, we know we'll get our breath back quick enough. But for people with breathlessness and in pulmonary fibrosis, they're a bit concerned that it'll take time. But remember, if you do pace yourself, you will get your breathing back. Pursed lip breathing is, if it's also appropriate, it can be helpful. And tummy breathing, focused breath, such as concentrating on a rectangle, say in your house, maybe looking at a picture frame. And if you breathe in through the short angle of the rectangle and you breathe out over the long angle of the rectangle, it can kind of give you focused breath and gain back control of your breathing. Airway clearance is also very helpful, and techniques for this can be taught through your physiotherapist. And as Grania mentioned, the stall breathing technique is really, really helpful. And she mentioned also keeping this on your person, maybe doing it and learning about it when you're well so that you can put it into practice when you get into a situation where you become breathless. So the first thing you do if you become breathless is you stop what you're doing. Try to remain calm. Know that your breathlessness will resolve once you settle it. You can turn up your oxygen for the period of your breathlessness, but remember to turn it back down to the normal concentration of oxygen that you are prescribed. Assume a comfortable position, for example, sitting or leaning against the wall, and letting your imagination wander to a place that makes you feel better or more relaxed. And then let your breathing return to normal control. So as Maria mentioned also, our palliative care teams in the community, they run breathlessness clinics. And again, I'm aware of them being a nurse in Dublin, of the ones that are in Harold's Cross and Blackrock, and also in St. Francis and Blanchardstown. But there are other programs run through the palliative care teams in the community throughout the country. And you just need to link in with your GP, who would be aware of the palliative care contacts that you need to make to get into these programs. So you can see with regards to breathlessness, these clinics that they run can address the cycle of breathlessness, which is really helpful because breathlessness is contributed to by not only what we're actively doing, but also what we're thinking. If we're anxious, we're feeling panicked, frustrated, we become more breathless. If we are becoming unfit and deconditioned, we become more breathless. And it becomes a vicious cycle. So the less you do, the worse you feel as regards your breathlessness. The other thing to think about here is that when you're exercising, it's very important to pace yourself so that when you start off, and even people that don't have underlying lung conditions, when they start exercising, they're more breathless at the start, and that's normal. So the same for you, even if with pulmonary fibrosis, when you start your exercise, you might feel a little bit more breathless, but as you ease into the exercise, your breathing will become better controlled and you'll be less breathless. So there are medications also related to managing breathlessness. And the first one that some of you may be on is oxygen therapy. This is usually ambulatory oxygen, we call it. So it's oxygen that you use when you're mobilizing. And you may need this more when you exercise on, say, a treadmill or an exercise bike. But when you're walking, you just need the prescribed dose that your healthcare provider has recommended for you. Opioids such as morphine sulfate can help manage breathlessness also, and your perception of breathlessness. Another medication that you might know of is Oromorph. Some of you may be on this, and this helps to manage cough also. Anxiolytics can be helpful in managing breathlessness. They aren't actually specific for breathlessness, but they reduce the anxiety and your perception of breathlessness. And antidepressants are also helpful for patients with pulmonary fibrosis, because in 80% of patients with pulmonary fibrosis have reported a low mood or depression. And this can impact on your quality of life. And it needs to be diagnosed and treated successfully by your GP and your consultant to improve your quality of life. Before I move on to cough management, I just want to mention a little bit about fan therapy. There has been research showing that fan therapy with the little handheld fans, such as in this slide, they are very successful in helping to reduce our perception of breathlessness and helping you manage your breathlessness. And they are available from ILFA and on the internet as well. So just the other topic I need to cover is cough management. And there are simple remedies such as adequate fluids to help keep your secretions moist if you do have secretions. And often cold drinks are good for cough management. Also lozenges, menthol, and honey and lemon, and ice cream, which one of us might like, and avoiding irritants and triggers. Mucolytic agents such as Exbutex and Mucodyne, which you might have heard of, these are good if you have secretions that you're finding it difficult to expectorate. Advice would be to have these earlier in the day so that they're not encouraging you to cough and expectorate phlegm later in the evening and night. If you have a dry, irritating cough, cough suppressants are good, such as cough linctus or Oromorph. And again, just to talk about the control of gastroesophageal reflux disease, protein pump inhibitors, which are Nexium, which you can get across the counter, but these really should be prescribed by your consultant, your healthcare provider, ensuring that you are helping with gastroesophageal reflux disease. And I mentioned earlier also raising the head of your bed or raising pillows lying in your bed will help with gastroesophageal reflux disease. Controlling nasal symptoms such as postnasal drip, you can use a sinus rinse, and if you don't really like sinus rinses, there is a Sterimar nasal spray which helps to improve nasal hygiene and reduce postnasal drip, which can cause more coughing and shortness of breath. Steroid sprays, when they're prescribed, just it's important that you use them correctly, so you should be shown by your healthcare provider, your respiratory nurse, and also antihistamines. And during coughing episodes, you can increase your oxygen therapy to help with these episodes and reduce the incidence of the coughing. So coping with stress and emotions, and I know Maria has touched on this a little bit, but what can you do to help? So get involved with support groups in the country. There are several of them all over the country, and information with regards to these support groups are available on the ILFA website. And these support groups provide a support network of people similar to yourselves who are in similar situations, and you meet these people and they can show you different ways of how they were able to do things differently to help them feel better. It helps you not to feel alone in your condition. And there are many people out there with similar problems to yourselves, and they are living full lives and working to maintain, their lung function and working hard on this. Attending your pulmonary rehabilitation, as Grania had mentioned earlier, these programs are run throughout the country. They are online a lot, I know, at the moment over the last year and a half, but they're starting to become back face-to-face, and they're a very good social interaction for people with pulmonary fibrosis. Then again, just to discuss about managing your symptoms and your side effects. So respect your strengths and your limitations, and take time to breathe. Choose leisure activities that you enjoy, and with regards to your side effects, they might be side effects with regards to your pulmonary fibrosis, so managing them as we have discussed with regards to your diet and your exercise. And then if you're on medication, managing your side effects with regards to these medications, ensuring that you take them as advised by your healthcare practitioner with food or at specific times during the day. Then relaxation techniques like your breathing exercises and using your stall technique is really important. And a lot of people have felt that psychological strategies teach us ways of dealing with stress and anxiety and panic. So meditation is very good, and yoga, and there is websites that you can join in order to join yoga classes online and meditation online. And then prevention and management of exacerbations. So with regards to that, we have to go back to looking at how we protect our lungs, preventing the exacerbations, avoiding contact with infected persons, and managing your exacerbations. The single most important message that you need to take from this is that you are aware of the signs and symptoms of an exacerbation, like your increased shortness of breath, your increased cough, and the importance of seeking medical attention as early as possible if you notice any change. And never be afraid to pick up the phone and talk to your healthcare provider, be it your physio or your respiratory nurse specialist in your providing care hospital. And then just to remember, if you can be anything in this world, be kind, both to yourselves and to your healthcare providers. And maybe very importantly, to your family and your carers. Thank you very much.
Thank you, Patricia. I'll just stop your sharing there. There's only one question in, and it's more actually a generic question. Just touching on transplant, has the criteria changed age-wise? It was mentioned earlier that the age is up to 65. Does that apply here now? I don't know. Does anyone want to take that question, or you might need to answer it afterwards? We might have to answer that afterwards. Okay, fair enough. I'll move on. Eddie, I'll just unmute you there again, and you can introduce Cian there. Just getting unmuted there. Okay. Eddie's having some problems unmuting himself, so I'll just pass on directly there to Cian there to start off.
No problem at all. Thanks very much. Can I double check that you can see the slides on the screen and you can hear me okay?
Yes, I can indeed, Cian. That's perfect. And if you just want to start the slides from the beginning there, yeah, that's perfect. Yeah.
Okay, thank you very much. So thanks very much to ILFA for inviting me here today, and I also have to just give a special thanks as well to everyone who was speaking before. The talks are both brilliant, and also they've sort of helped set the scene a bit for some of what I'm going to talk today. So to let you know who I am to the audience, I'm originally a pharmacist by trade, but I now am a lecturer in RCSI, and I lecture in pharmacy. But what is of relevance here today is that I lead a research group in which we are trying to understand pulmonary fibrosis in terms of what's happening at the more microscopic cellular level in terms of the disease. And we're also trying to then develop new drugs as a result from what we learn. So I'd like to keep it today, try give a snapshot of some elements of what I'm going to talk about related to inhaled medicine. And really what we're going to cover today is, first of all, I'd like to give you the pharmacist perspective of why are we interested in developing inhaled medicines instead of oral medications. Then talk a bit about the context of what types of medicines are being looked at in trials for inhaled development. And then move on to a direction in terms of some of our work that our lab is interested in, which is this concept of drug repurposing. So we'll explain more of that later in terms of the type of work we've done that has been supported by ILFA and where we're going in the future. Lastly, though, I'd like to conclude with really just to reiterate a summary in terms of what I'll talk about today. A lot of it is our perspective in terms of what we think can be useful in terms of the medication or being useful in terms of how to deliver it. But ultimately, we want to make medicines that have value and impact for people with the condition. So I just want to conclude with some comments and some thoughts on starting to start that process, I suppose, of understanding people with lung fibrosis, what their perspective is on inhaled medicines. So why choose the inhaled route? And really the idea here is that what I've done on the screen is put out some advantages and challenges for both delivering medicines by inhalers versus delivering them by oral. There's also a question I noticed in the chat about an injectable medicine. I'm happy to take that as well on this slide. So why, from our point of view as pharmacists, do we think inhaled medicines are very useful for lung conditions? Well, really beyond the fact that you might naturally understand that when you have a condition in your lung, it is beneficial, if possible, to try target the dose or your drug directly into that site. So the real idea here is trying to get almost more bang for your buck with a drug, and that's both in terms of the benefit, but also in terms of reducing the side effects that might be present. And of course, this is of particular relevance, we believe, when you think about IPF or other interstitial lung conditions with the current medications that are there. So the idea here with any inhaled medicine is that you can deliver a lot lower quantities of the drug. And because it goes directly to the site of action, even though you deliver a lower amount of the drug, it still has a greater concentration in the lungs. That means that you're getting right to the heart of the condition, in which you hopefully bring about the therapeutic effect. Now, this is also useful because it delivers less systemic side effects. So when I talk about systemic side effects, I'm talking about when you, for example, have an injectable medicine or an oral medication. When your body absorbs this medicine, it is subject to being distributed all around the body. It could go to the lungs, but it also can go to other sites in the body, other organs, other tissues, affect other cells. And really, that in itself can lend a drug to being susceptible to causing side effects that are not what you want, of course, for the medicine. So systemic side effects can be anything related to the skin side effects of pirfenidone, of Esbriet, or versus the gastrointestinal side effects that might be there as well with some of the other medications. So they potentially can have a systemic impact on that. And so I think one question in the chat there was asking whether a cutaneous version of pirfenidone or nintedanib could be beneficial. Well, again, I can only speculate to a certain degree because it hasn't been formally tested, but I would strongly believe that pirfenidone, if administered by injection, could still have some of those same systemic side effects associated with it, and potentially nintedanib as well. It might reduce some of the gastrointestinal side effects, but that's not necessarily, you're still going to have the systemic exposure with an injection. Now, on the flip side, with inhaled medicines, of course, it's important that there's utility. We really need to have medicine, an inhaler that is going to be useful for a person in terms of them taking it and not being a nuisance for them, and it having a beneficial impact for them and on their condition. The inhalers themselves must be practical ultimately. We need to be able to have something that might be portable, that might be easy to use, that's not too complicated in its operation. We need to bear in mind that some types of inhaled medicines might have to overcome this barrier of that someone might have reduced lung function as a result of their condition, and as a result some inhalers might not deliver as effectively into the lungs. Technique with inhaler is complicated for everybody, so again we would like to ideally try to create a device or a system in which that it is a simplified technique and there's appropriate education for people to help them use it. And then from a pharmacy side of things, inhalers have challenges in terms of that the type of way we make the medicines can have more problems with the stability of the drug itself, or how it can stay in a stable form in terms of being dissolved in some preparations that are nebulized. Now compare that to oral medications. Of course, oral medicines are the most common types of medicines in the world. They're convenient, they're simple to use, and from a pharmacy point of view, they're easy to make and scale up in bulk. The challenges, of course, sorry, was there an interruption?
No, continue on.
Yeah. Thank you. The advantages essentially are inherent because, of course, we're generally pretty comfortable, all of us as a population, with taking medicines. We might necessarily want to take them, but when we do take them, the oral route generally tends to be relatively straightforward. However, of course, when you have medications going into being swallowed, you can have specific effects in the gastrointestinal sense, which of course both of these medicines can have, particularly with OFEV more so. Systemic side effects because again you will absorb the drug through your gut, but it will be distributed all around the body. And then the last point as well is that if we're trying to think ahead to IPF in comparison to other conditions where you have many medicines, you might give someone not just one medicine, but several medicines to help almost synergize and bring together an improved antifibrotic effect. The problem here as well is that drugs can sometimes interact with other drugs and have negative impact. And this is something that is most prominent as well with systemically administered medicines versus inhaled medicines. So in a nutshell, for us, there are challenges and advantages of both, but this is why we believe that inhaled medicines do have a place in thinking ahead to what we can do to help manage IPF more in the future. So we're the only people thinking in our lab. I just really wanted to highlight that there are a lot of clinical trials actually at the moment that are investigating inhaled medicines in pulmonary fibrosis, in IPF more specifically, but IPF generally tends to be the first condition analyzed, and then they explore other types of lung fibrosis conditions that might be present. We've identified about 13 to 15 studies that are there in trials, but I've just highlighted 3 to try give you a broad taste of what kind of stuff is tested. So first of all, you have brand new drugs that are in the trials, and they've never been given in any shape or form for a condition to a person. So I've an example there in the top left of this company called Galecto that's making this inhaled medicine, and the drug is new, so it doesn't even have a drug name yet. It's called T139. And this essentially is targeting this new pathway in IPF. And again, it's really just to illustrate that you can have new drugs that are being made in the inhaled sense that are brand new and under trials. However, you also have people looking at current drugs and seeing, can you deliver them now by inhaled versus oral? So this company, Avalyn Pharma, has actually recently completed studies in which they are giving pirfenidone by the inhaled route. So they're trying to address the fact that pirfenidone has, of course, those systemic side effects, and can they be reduced by delivering an inhaled dose? And some of their initial work in a phase 1 clinical trial seems to indicate that there can be less side effects with the inhaled route and perhaps a maintenance of the same effect of the drugs. However, what of course is an interest of mine, and one that is also an interest in the field, is this idea of repurposed drugs. And this was perhaps most prominent in a study earlier on this year where there was this drug called treprostinil, and they were looking at this in patients who had pulmonary hypertension. And what they noticed was in a certain subset of patients who had pulmonary hypertension, a subset of patients who had also IPF actually got an increased benefit of this drug. So this is an example of a medication that was originally actually an injectable medicine, has been converted to inhaled medicine, and they've even identified that it not only helps with one condition in the lungs, but can help with another. And now I believe there's a trial underway where they're starting to build up a trial to look at this Tyvaso drug in IPF specifically. So this filters on into what I myself in RCSI am interested in terms of repurposed drugs. So to explain that a little bit, the idea of a repurposed drug is that you have a drug in which we have already used it for something in people. So we typically have a drug that maybe has gone off patent. It might have originally been used for heart disease, for diabetes, for something else. And we investigate it more and we realize it also has potential for other conditions. Why is this useful? Well, because if we use a medication that we know has been used for decades in people, at a minimum, we know it's a safe medicine and we know it's okay to test it in the population. And this really can advance drug development by bringing new medicines to market sooner. So I'm trying to illustrate that here in this slide, and I do appreciate there's a lot of text in the slide, so just to try put it in context. If you look at the top, you have this pipeline almost. On the left-hand side of the pipe, you have the beginning of the drug discovery process. On the right-hand side, they say market, but what's more important is clinic there. That's when it's going to people. So typically, designing a brand new drug can take anywhere from 12 to 15 years. They even say 10 to 17 in this reference, but generally 12 to 15 years is cited. $2 billion to $2.6 billion worth of research and development go into it. And quite often in the final hurdle in the clinical trials, unfortunately, the drug can found to not be effective in people and it fails. So if you compare that to the pipeline of a repurposed drug in the bottom right-hand side of the slide on your screen, you essentially can knock off a significant amount of time by starting with drug molecules that we already understand the safety of and how they work in the body. So what does that mean? It means that medicines can potentially, if they are beneficial in IPF, be brought to market sooner. Consider the fact of maybe 6.5, even though it can go up to 10 years potentially, but on average 6.5 years versus on average 12 years. Think about the fact that it's cheaper to make. That, of course, might not impact people with IPF personally, but what it means is that there is more appetite or more potential to bring these sooner without having a significant cost barrier for certain companies or charities that are involved in developing these. You, by virtue of the fact you know the medicine is safe, you generally tend to get less failure in clinical trials. And again, by virtue of the fact that we know the medicine is already safe, we generally tend to have the potential to go through the regulatory process of making sure that it's okay to be used in people faster. And this is really where our lab is interested in. We identify drugs used somewhere else in other conditions not related to IPF, and through our understanding of the cellular mechanisms, so what's happening in the cell in IPF and the disease, we identify drugs that might have anti-fibrotic potential, and then we repurpose by reformulation. So we take these medicines, which are usually oral medications, and we try design new inhaled formulations for them that can be delivered into the lungs directly for the maximum effect. So just to try to put that in context, it's been very well explained already earlier today, again, for which I'm very grateful and thought was very interesting. But I've just shown a schematic here in terms of the core components of what's happening in the actual alveolar region, the area of your lungs where you have gas exchange with fibrosis. So on the left-hand side of the schematic is the idea of that we have certain types of cells present. You have these alveolar cells, and underneath them you have a small quantity of fibroblasts, and gas is able to be exchanged. Where on the right-hand side of the schematic, what you have is if something happens due to the idiopathic reason for the condition, the alveolar cells become, they start to spread the disease essentially. So what happens as a result is they interact with the fibroblasts next to them, and those fibroblasts are really what causes scars in your lungs. There are also some inflammation cells involved with that. Now, again, this is just a short information session, but what I'm highlighting here is what we do is we look at these as core components of our targets. We try to understand what happens in the alveolar cell, the fibroblast, and the inflammatory cells. And we like to look at our drug in terms of understanding how it can reverse the disease-like effects of these cells and hopefully bring about an antifibrotic effect. We are also interested in not just looking at our drugs alone, but also looking at them in combination with pirfenidone and nintedanib, and work in our lab with our off-patent drugs has actually shown that if we, with human cells, so these are cells, of course, in a lab, so it's early stage in the process, but if we add our drugs to pirfenidone, we get a better effect than pirfenidone alone. So we're hoping to try build up potentially a future in which we can have more than one type of antifibrotic given together in combination therapy, which is just not possible right now due to the drug side effects. So it is a long roadmap ahead. This really started with ILFA's funding for us in 2019 to 2021. That helped us do a lot of screening of a lead drug that we've been exploring, and we've explored that in cells that were donated by patients internationally that we've looked at, and we've identified drugs that look good essentially in terms of having potential for inhaled medicines. What we are doing now is this funding we received from ILFA really helped us put forward a case to Enterprise Ireland for a greater amount of funding, in which we're now actually going to explore converting those drug molecules into new inhaled medicines. So the context, though, needs to be important, that we are at the far end of this drug development pipeline. We have identified our compounds, but we need to work now on trying to actually make them into real medicines. And that in itself could take, realistically, another 10 years. And that, of course, might not be useful to some people who are listening on the line, but ultimately what we're trying to do is create a future, I suppose, in which we can create new options for people and to have inhaled medicines there. But it is all about the people at the end of the day who have the condition, and that's where the final perspectives come in. For us, we think inhaled medicines are very useful and can be the way forward, but the best people who know this are the people who have the condition. So I suppose some concluding remarks, perspectives I'd love to think about, and if there's any feedback on it today, it would be fantastic. But if there is not, even perhaps my talk with ILFA and Futures would be great to get an understanding of what do you as experts about your own condition? Do you think that there's a place for inhaled medicines in IPF or your lung fibrosis condition? Or is it just not practical, not feasible ultimately for people? If there was one type of medicine inhaler used for those who have had experience of nebulizers or dry powder inhalers, there are different types of inhalers out there that have benefits and advantages. We want to try find the best one for as many people as possible. And lastly, I suppose, in terms of thinking about all we've heard today about it being important to live your life and to, not, I suppose, do our best to try to not have the condition own us. We also want to make sure our therapy that we potentially develop is not disruptive to people. So I suppose if there are any key factors that we think you think are important to think of when if inhaled medicines are being made, what kind of things could we potentially design into that to make life easier in any shape or form? That's really important information, because ultimately what we want to do is potentially make medicines that can help you with your condition. So that's it, really, just a quick snapshot, hopefully putting context of why we think inhaled medicines are important. A lot of funding goes into the group. This is just a picture of 2 departments in RCSI, but my lab in itself is made up of a mix of around 10 researchers at the moment. And just thank you very much for your time for listening today.
Thank you, Cian. Actually, a good question here from Grania. For Dr. Cian O'Leary, does your department utilise the anatomical gift programme? Is this an option for IPF patients who wish to donate to science?
Yes, as far as I understand now. Again, I will preface this that by virtue of being in the pharmacy department as opposed to the anatomy, I don't know all of the ins and outs of the exact mechanism, but yeah, we usually are involved with this. So what I would say is if anyone is potentially interested in that, I'd be happy to look into it, and we can put in touch, or I could inform ILFA on that. But yeah, our anatomy, we use, there are donated samples and specimens, of course, for people in that, but I don't know the exact mechanism of it personally, sorry.
Okay, no problem. A lot of questions coming in, that some very personal questions that will get addressed after the webinar itself. We're just conscious of time, so, and we do want to get to our last speaker there, so I'll let Eddie introduce there.
Thank you. Thank you. Our next speaker is Annette Cremin from Dingle, County Kerry, and we're delighted to extend a warm welcome to Annette and look forward to hearing her perspectives on living with pulmonary fibrosis.
Thank you, Eddie. Dúis bhhailm buchas a gháil the common fibrosis scabhógan a héireann as an cura chun caint living up. I want to thank you very much to ILFA for allowing me to speak. And as you said, I come from Dingle, County Kerry. I'm a retired nurse. I've worked in Dublin and I've worked in Galway, and I've also worked in the United States in Fort Worth in Texas, and I also worked with Viator Christi, which is a Catholic organisation in Ireland, as a volunteer in Nigeria for 2 years with Holy Rosary Sisters. So my introduction to pulmonary fibrosis began at the end of 2009, when my sister Joan came home at Christmas complaining of shortness of breath. Now, she did come home in 2008 complaining of shortness of breath, but it was put down to her, she had an underlying heart condition. However, when she did come home in 2009, she had been well all the year, and she just had this one episode of shortness of breath. However, she was admitted to hospital in Tralee in the Bonds, and she was diagnosed with IPF, and she died on the 3rd of July 2010. She lived for 6 months with her diagnosis, which was very virulent and very traumatic. So that was the first I knew about pulmonary fibrosis. I really hadn't heard of it. I didn't know much about it. So I was introduced with then. And so I knew about it. I had seen things on Facebook about that it was ran in families, because there were support groups and there was fundraising. So I just went ahead with my life. And at the end of 2017, I got a cough. And because my sister's, I suppose, passing was so traumatic, I hadn't looked up the signs and symptoms of pulmonary fibrosis. So I put down the cough to probably maybe my heart. But I had also decided that at the beginning of 2018, I was going to have an MOT on my health. And I had also asked my GP, I wanted to speak to the respiratory physician who is in the Bonds Secure Hospital in Tralee, the only respiratory physician in Kerry that I know of. And I wanted to talk to him. So I went ahead, I had my different bloods and everything done, and I also had a chest x-ray done. So when I went back, so then that was that. I didn't take too much notice of anything, and I was sitting at home one night watching television, watching Ray Darcy's programme, a Saturday night television show, and he had this lady on from the United Kingdom, and she was on about a different thing. She was on about her son who had special needs and who was being bullied. And she said, I wouldn't mind, she said, but my mother, who was helping me in every way with my son, has been diagnosed, she said, with a terminal illness, and I can't pronounce it. But she said, every time I hear somebody coughing, I just get worried. And I just sat up in the sofa and I said, I have it. It's pulmonary fibrosis, I have. So then I looked at the signs and symptoms and saw that it was. So I went back to my consultant, and I was getting on my results, and I asked him, Doctor, what way was my what way are my lungs? And he said, well, now we'll talk about that later. So I said to myself, well, you definitely have it. So that was it. I went to my consultant and he said, yes, you have fibrotic changes in your lungs. It's early, but I cannot give you a definitive diagnosis until I do all the tests. So I had all the tests for pulmonary fibrosis. And I went back to him and he said, yes, unfortunately, you have pulmonary fibrosis. And he said it was an early diagnosis. And I was put on nintedanib, and I was managing on nintedanib for about 6 months, and then I started to have a side effect of diarrhea. But I managed to stay on it for 2019. I was diagnosed in May 2018, so I was on nintedanib until the very beginning of 2020, when things got exacerbated and I had to come off it, and then I was put on pirfenidone, and I have been on pirfenidone since. Unfortunately for me, I have other medical conditions which don't help. However, I'm on it and I seem to be doing okay. And there is very little more for me to say, because the speakers today were wonderful, and they told us all about exercise and singing and everything. So there is no need for me to say much more about that, except to say that I am doing everything that I possibly can to help my lungs and develop my lungs and all that goes with it. So really, what I want to say now is when we had our last information day, Sean O'Shea, who comes from this area, spoke eloquently about ILFA. And I just want to add to that. We are special thanks to Eddie, Nicola and Gemma and all the backroom team, because without them, the help is just fantastic. It's wonderful. They're there at the end of a phone if we have any problems. So I'm deeply grateful to them. And I just want to finish off, because I just thought this was a bit interesting. And it is really the medications and the cost of the medication. So I went and found out that in pirfenidone, 1 month supply of pirfenidone costs €2,587, and 1 month supply of nintedanib costs €2,681, which means that as my pharmacist said, our medication per tablet is approximately €43. So that's all I have to say. And I want to thank you all for giving me the opportunity to talk on my trip to pulmonary fibrosis.
Thank you so much, Annette. I'm just going to hand back over to Eddie. There's no other questions. So, yeah.
All the questions. Right. Thank you, Annette. Very informing, I have to say. I wish you all the best. At this point now, we're approaching the end of our event, and I would like to offer my sincere thanks to all our speakers. Unfortunately, Dr. Keane, I wasn't able to introduce you for whatever reason. My sincere apologies. So I think all our speakers today were very eloquent, very informative in every way. I would also like to extend our thanks to Gemma for all her work and dedication with organising the event. Just to tell you, we have a new person on the team, Anne Griffin, and if Anne is tuned in, the best of luck to you too. Special thanks to our Justin, who with his expertise has steered us right through the morning. Thanks again, Justin. I also want to acknowledge the work of our committee. They dedicate their time, their talent to run ILFA really effectively. I am enormously grateful to them for all their hard work and their commitment. Our fundraisers also deserve special praise, as ILFA would not function without all of their efforts. ILFA is dependent totally on donations, and all support is greatly appreciated. I would like to, if you would like to fundraise for ILFA, please get in touch. We would appreciate it. If you or your family member is a member of a club or a society or a company, please consider ILFA as a potential charity partner. We would welcome such an opportunity. We hope you enjoyed today's session, and I hope that it was informative on every aspect. I would like to express our deepest thanks to Boehringer Ingelheim for kindly supporting this event. I hope you all have a very pleasant day. I know it's only November, but there's a festive season coming up. And in case I'm not in touch with all you people, I wish you all the best and have a lovely weekend, and please stay safe.